Yes, because it's like saying there's going to be zero death. We all die at some point, and some of us die by suicide, and some of us die by cancer. I am Dr. Carol Bernstein, a professor of psychiatry and neurology at the NYU School of Medicine.
Welcome to the 9th episode of the MD Edge Post-Call podcast. I'm your host, Nick Andrews. At MD Edge, we understand the massive concerns surrounding physician burnout. But in this episode, I dive deep on the differences between burnout and depression with Dr. Carol Bernstein. Dr. Bernstein is professor in psychiatry and neurology and vice chair for education at the NYU Langone School of Medicine in New York City. From her Manhattan office, part 1 of my conversation with Dr. Carol Bernstein. This is the second time that I've met you and we have done one of these together. Last time I was producing, and it was a conversation with Dr. Lorenzo Norris, who is, of course, the host of the MD Edge Psychcast, and I'm so glad to have you back.
I am delighted to be back, Nick. This is terrific.
Yeah, it's really fun. We kind of delved into something really fascinating last time at a topic that is near and dear to our hearts here on this show, which is physician burnout, lifestyle, physician suicide, health, well-being, and a bunch of different topics. And the conversation between you and Dr. Norris got interesting for me when you wanted to differentiate the difference between
burnout and depression.
Depression
right.
For doctors, yes.
In fact, I'm trying to work on a paper about that with Drs. Maria Oquendo and Laurel Mayer. We'll see where it goes. But there are a lot of issues out there in the world because people are talking about burnout and depression as if they're the same thing. And they're really not. There's now some conversation about whether for some people burnout is a subset of depression. I will leave that to the DSM 6, 7, or 8 people to try to distinguish. But in general, burnout is described as an individual's response, which has a series of characteristics, to systemic problems.
Sure.
So, that makes it different just definitionally. And I think it will help us to talk about it because it's a colloquial word. And we all use it colloquially. So what it means to you and what it means to me could be very different.
Sure. So hold on just a moment. I think I'm going to... Okay, so now I understand what you're saying, but here's where I get a little confused. So how does this relate to the differences between burnout and depression? How does that relate to the noticeable rise in physician suicide and I guess others like morbidities?
Okay, so let's back up a little bit.
Sure.
There has been a rise, according to the CDC, in suicide in general in the population. There are a lot of perhaps reasons why this is happening. I can give you a few that I think, but it is not scientifically.
Just hypothesis,
my hypothesis, scientifically based, and then we're going to talk to doctors. Anyway, that's another conversation. But number one, we are recognizing suicide. So in the past, no one would ever talk about it when someone died by suicide. They would say, oh, this person had a heart attack, or this person died, or whatever, and they wouldn't say that the cause was death by suicide because of the stigma and shame attached to that. So there's no question that that's part of it, certainly not all of it. My own feeling is that we have become increasingly isolated in our worlds. With all of the wonderful things that the internet has brought us, even things like podcasts, and all of that, the personal interaction between you and me, Nick, is different than even people who are listening to this podcast or people I talk to on my radio show or what happens on TV or FaceTime or Skype. It's not the same. And I think certainly in this country, I can't really speak internationally,
Sure.
we've really lost a sense of community and of caring about each other. And some of that's driven by a lot of what's going on in the larger social milieu, where I think for lack of civility is certainly a big problem.
Okay.
We can talk about that. That's another topic.
Sure.
But when people are feeling like dying by suicide, it can be impulsive, particularly in younger people. And it's a feeling state, what we call an affective state in psychiatry, that's really, really, really unpleasant. But it does go away. It's not there all the time. And I think if we can help people both tolerate the feelings by being connected to other people and get treatment that will help them feel better, that we can address this. But there will never be zero suicide. It's like saying there's zero death.
Yeah.
But
I find things, like that's a weird...
It's a weird concept.
A weird goal.
I think it's a bad concept, frankly.
And it's not just for suicide. And like I'm not, like I say this all the time, I call myself a medical muggle, if you're familiar with Harry Potter.
Yes.
Yes.
Okay, you can be a muggle and I can be Harry Potter.
I suppose you would be a professor because Harry Potter's Harry Potter's the student. But when I hear zero suicide, like that should always be the goal theoretically. If you enter it understanding you'll never reach the goal.
Yes, because it's like saying there's going to be zero death. We all die at some point, and some of us die by suicide, and some of us die by cancer, and some of us have heart attacks.
Are you telling me that I'm going to die someday?
I don't like to think
Dr.
that either.
Bernstein?
No, Nick. I'm with you. Forget it.
Yeah.
But anyway, you get what I'm talking about.
I feel you for sure. So the isolation thing is something that I find very fascinating because I, as a literary nerd, have argued that postmodernism, this idea of Hemingway and Fitzgerald and Faulkner and all, it has ended recently, and now I think that we're in a period of reflectionism, where everything around us is just a mirror, and we just see what we're presenting to everybody, and there's like a glass between us and everybody else.
A distance, yes, and that's not good. I think that human connection is the essence of who we are, and without that, it's like, why bother? I mean, I think of Emil Durkheim's Enemy. That's what I remember. But I was a political science major. So, the sociology and political science of all of this is really important. I want to get back to the doctor piece.
Yes, let's do that.
So I don't know that there's been a rise in doctor suicide anymore. I mean, really, the issue is that doctors who die by suicide, at least some of the literature supports this, have different characteristics than the general public who dies by suicide.
Sure.
I wish I could. I hope I'll get this all straight. Yeah, off the top of my head. So one, they're more likely to have had a problem at work. They're less likely to have had a loved one close to them die. They're more likely to have high levels of benzodiazepines and barbiturates in their blood because they're treating themselves. They're more likely to have a mental illness because they don't go for treatment because of stigma. So those are all factors that are different in the physician population. And I'm going to say something else, which is that people who go into medicine, and this is a generalization, so I'm sure you'll understand that, they're perfectionistic, they're obsessive, they have really high, they're really aspirational in what they want to do. I mean, they're going into a profession where they want to save lives. And when they fail at that, it can be very devastating. And so there are personality characteristics that go into the group that become physicians. And maybe those characteristics also contribute. It's certainly not a oneer. Sure. It's not the only thing.
Yeah, okay. So that makes sense to me. And I guess I've always had a problem with big, broad generalizations and statistics in general, just because if you want to say the national suicide rate, but like, there are 300 million people, and the suicide rate, because I grew up in the Rocky Mountain West, and the suicide rate among Native Americans is absurd.
Right.
It's an epidemic. Statistically, it's like one a day in some of the places in Canada, which is a completely different subset of issues driving their suicide behavior. Like the average age I read in Canada was like 15, which is crazy.
There's a lot of substance abuse in the Native American communities too. We know that. So I do want to say this, that we know that there are certain things that put people at large risk for suicide. Substance abuse and mental illness are two of the big ones. So that's important to remember. I had another thought, but it flew out of my head.
Yes,
but,
we'll catch it.
But it was related to that. And so different groups have different risk factors. Oh, the other piece is there is still what we can do. We can't have zero suicide. What we can do is improve access to mental health care, which is terrible in this country. So we know that having a mental illness is a risk for suicide, and yet nobody can get access. There aren't enough mental health care people. There's certainly not enough psychiatrists, and there's huge stigma about going to see a psychiatrist.
Yes.
So you have all of those factors as well.
Like I mentioned before, where I grew up is a big, bad, tough Western state, and I always encourage people to seek help because, like I always said, well, if you were lifting weights today and your knee popped, but you're okay, I said you would go to the knee doctor. But if you're waking up every day for a month and you
Feeling
like
terrible.
can't, like, don't want to start the car, you got to go to the head doctor. It's not a big deal. But in medicine, there's a different stigma. I guess it could be similar to what I grew up with in the West in a way,
Right.
in that you don't want to admit this. And that because of the hierarchy in medicine, I can't have anyone I know knowing that I did this.
Well, it's also that, making mistakes. People are so they have very high aspirations, and when they don't meet those aspirations, they're much more ashamed about it than other people. So I think shame plays a big role. The other problem, and we're really making progress here, the other problem is people are worried about credentialing and licensure. There are many, not many, fewer states now, but there are states in this country where on your licensure questionnaire it says, have you ever been treated for a mental health condition? Have you ever seen a psychiatrist? They never say, have you ever seen a doctor? So the Federation of State Medical Boards is finally trying to address this. But people are afraid that if they acknowledge that they're struggling, that they'll be removed from medicine, much like I think it's true in the airline industry as well.
Yeah, that's really interesting. Yeah.
Right. And that there is somehow this idea that if you have depression or anxiety, that you can't do certain things, which is not true.
Yeah,
it's
and
not true.
I find that in mental health, and you can correct me if I'm wrong, as I'm just a muggle. I
like this muggle stuff.
Yes,
really.
It's not bad, right?
I like the muggle
Thank
stuff.
you, I appreciate
Yep.
that. I find that as we look through the history of mental illness and we start connecting it with neurology and other different nutritional aspects, we find that more and more of the diseases they both have more complex pathways than we thought, and they have their spectrums.
Brain diseases. Yes, that's correct.
And if there is a spectrum, then like by definition, theoretically, once you're there, you're on the spectrum. But at what point does it become a disorder? Say, I have been treated for depression, but I'm good now. Do you take the person on their word for it? How can we find ways for these high-level industries?
It has to do with impairment. It doesn't have to do with diagnosis. Because in fact, our diagnoses in psychiatry now are all phenomenologically based. They are not etiologically based because we don't know the etiology. So it's really that what we've seen, and it all started, and we just had a grand rounds this morning on post DSM-5, the Diagnostic and Statistical Manual, that these are clusters of symptoms that we've decided to call, quote unquote, a disorder or a disease. But what really matters, like with anything else in medicine, is how impaired are you? So you can have depression and not be impaired. You can have cancer and not be impaired. But you can have cancer and not be able to function. And you can have depression and not be able to function. So that's what's important, not the disorder.
Sure. Now that makes 100% sense to me. And I think we get in fights with some of my resident friends in Philly. I explain to them why, like if somebody makes a typo and I'm reading a story in the Wall Street Journal or BuzzFeed, like whatever, that's annoying, fine. But I get much more aggravated when there are typos and grammatical errors in medicine. It's like, and I explain to them the difference and why I got so angry with a cancer patient versus a patient with cancer. Because a patient with X
right,
is
exactly.
not defined, and it's a big thing, right?
I'm going to give you an English language thing here.
I'm excited.
We don't say somebody committed suicide. Commit means like commit a crime.
Sure.
We say died by suicide.
Died by suicide.
It's the same thing. So if you, as you talk about it, can refer to death by suicide as died by suicide, it's the same as saying the cancer patient versus the patient with cancer.
Right, and like those points to me are, and it seems almost subconscious, where you don't understand why you're such a stickler about this thing or that thing, but it is a huge
deal. The language helps. Oh, I was going to say something else. One of the biggest a big challenge in psychiatry and with mental illness is that these are disorders of how we feel and how we think, the very essence of what it means to be human. So it gets really tricky. People are worried. If I have this illness, whatever you want to call it, does this mean I'm not human? Or how many people have said, well, of course you're depressed. You just lost your job. Or of course you're depressed. You just had a miscarriage. But that's not true. Depression is a discrete entity. It's not the same as just being sad. Mm-hmm. We all get sad.
Yeah.
But depression, we're trying to look at depression both biologically, environmentally, psychologically as a something. And it's like, I don't want to split hairs about it. just to say, for example, if I think a medication is going to help someone's mood, I'm going to try it. I don't know that means that person has a disorder. It's just not, I don't care. What I care is helping the person feel better.
Yeah, and I think, there's a lot of places we could go down.
Right.
As far as treatment is concerned, I guess I'll just talk about what my own situation is. I was diagnosed with ADHD at the age of recently. Like 25.
Recently,
So,
okay.
what's really interesting, and this is indicative of where I grew up in the mentality of this and that. My parents were approached by teachers when I was 5, and they said, this is weird. This is not, because like my mom observed me, and the story goes that I was playing with bricks, and I was like, bugging girls, and I wasn't paying attention, but then the teacher would call me, and I knew what was going on. But I needed the activity so badly to function. The flash forward to I'm 25, I just graduated college, I'm like, all right, let's do something about this, and I got Adderall for the first time, and yes, methamphetamine is wonderful in like a pharmaceutical dose, but I thought to myself, this would have been a game changer at the age of 14, and now I can tell you that pharmacologically, anything that's a controlled substance, in my experience, has been, I don't love that I have a crash day if I don't take it for 2 days in a row. I hate that, but at the same time, I don't want to take it to get high. I want to take it because I'm functionally a different, and it corrects the thing that, I thought like my education would be different if I had been taking
Well,
this
let me
as a
tell you,
teenager.
my kid was, I'm a psychiatrist, right?
Yeah.
At 8, we put her on Concerta. Now, it's interesting because there are several things that go on with ADHD, and some of it is correctable with medication, and some of it is the brain development is different in people who have ADHD. So as you get older, you do develop more capacity and more what we call executive function anyway. So the tricky piece is when you're a kid, I'm just guessing, I'm not diagnosing you at all.
Sure.
I'm guessing that when you were a kid, it would have helped some, but not as much perhaps as it's helping now, because you've learned mastery. And part of the problem that I had with my daughter was she thought because she took pills that she didn't have ADD anymore, when in fact she still had terrible trouble concentrating and focusing. So she thought she was stupid. That wasn't true at all. And she just needed extra tricks, extra skills,
and
the things you do to help yourself out.
That's the part of therapy that I missed out on, and I think I'm starting to transition to. I would like to be on a smaller dose of Adderall and eventually not have to take it.
Well, and there are Adderall. I'm not a fan of Adderall. This is me personally, because it's so easily abused.
Yeah.
There are longer acting preparations that are not so easily abused. You might want to talk to. I'm sorry.
No,
you're fine.
We have conversations about. I tell her, like, I wish I could go to the Adderall store and get like extended release this dose, because like these days I don't need this, and but I look back and I think that the therapy and the tricks would have gone a long way when I was a kid, because the telltale sign, when I was 25, I walked in the psychiatrist's office and I put his pen in my mouth, and he's like, that's an oral fixation, what are you doing? I was like, I like all my remotes as kids are all chewed up, and like now looking back, like, wow, this is literally a checkbox. My parents were against going to the internist in our small town and just getting a script, so they said, he'll deal with it, it'll be fine.
Well, and people are very opposed to medications because they think they're supposed to control it, and also it's because it's medications that affect our brains.
Yeah, and it's tough, because I have, and this is, we'll swing this back around to other controlled substances for depression. I have taken it specifically before because I knew that I don't need to focus today. I can have an off day.
Right, exactly.
I want to avoid the crash today.
No, well, my daughter has said the same thing. She starts to feel weird if she hasn't taken it. That's sort of the reality. And frankly, there was one day, this is just sort of a funny anecdote. So her Concerta, it was the Ritalin, it was the methylphenidate, because you can boost the Concerta with methylphenidate. It looks the same as Lipitor, which I take, right?
No.
So one morning, without thinking, I took the Ritalin, and I realized it right away, but I had taken it. I felt horrible. I really felt horrible. Now, maybe if I was a college student trying to stay up all night and study for exams, it would have been okay. But it's not like it made me feel good. It was like,
I mean,
So I
it's
think
an amphetamine, right?
right,
So it's
that's
a
correct.
drug, and then you could abuse it, and like
That's
the
correct.
meth epidemic and all. It is a drug, right? It's a controlled
Right.
substance that can be abused to get high for fun, but it's not the only one. Obviously, when you're
Right.
swinging this back around to depression, I think that if you are a physician or an airplane pilot or a soldier and you are prescribed buprenorphine, that you are going to have the stigma like, am I going to take this today so I can get high and not feel bad? Or at what point can I wean? Or do I need this?
Buprenorphine won't make you high.
No, but they think it will, right? Well, not physicians.
No, but it's to prevent withdrawal from alcohol.
Yeah, and also opioids, correct?
I'm not maybe the opioids, but certainly the alcohol.
Certainly alcohol. I guess
Certainly
I'm
the-
referring to antidepressants.
Okay, antidepressants don't make you high.
They are. I'm talking about like Xanax, etc.
Xanax is not an antidepressant.
Oh, see, learn me.
Yeah,
Yes.
I'll teach you. Yes. Xanax, remember I was referring before to the higher levels of benzodiazepines
Yes.
and barbiturates. Benzodiazepines are a different class of drug completely. That's the Valium, Xanax, Klonopin.
Those
And
are abusable.
What?
Those are abusable.
Those are abusable. They don't make people high, but people can zone out from them, which is kind of the feeling, I guess, I've never done this, that you can get from doing heroin,
Okay.
So you can, and they're hard when you're on them. You have to be careful when you go off them. There's definitely use for them in psychiatry. They are what's called a Schedule II drug, which means you have to include your DEA, your drug number on it, not just your
Sure.
regular license number. And they have addictive potential, and they can be sold on the streets. But it's more of a zone out thing. It's not a
Kinda
pep
loopy.
up.
Yeah,
It's
no,
not-
yeah. I understand
It's
that.
more like getting
But
stoned.
Are the
okay?
stigma for someone who just takes it because they want to study, and a stigma for someone who takes Xanax to enhance getting drunk?
Right, and you wouldn't take Xanax to study.
Right.
You'd probably abuse the Adderall to study.
Right,
but,
correct.
Yes.
Yeah, that makes sense to me.
right.
So, but if you had depression symptoms or mental health issues, do you want to avoid those medications from the stigma that comes with them?
Well, I think people don't distinguish. I think it's the issue of taking meds, and the issue of compliance in medicine in general is problematic. I mean, I'm on 2 blood pressure medications. I'm religious about taking them, but people forget they don't take them. Their doctors get upset, and people say all the time, I want to get off these because they feel like they're putting something external into their bodies, and they want to be, free and pure and
Organic
natural.
and- yeah, sure.
But I think with the antidepressants, it relates to the stigma of what just taking depression and anxiety, which are the most common disorders, because we all get anxious and we all can get sad. So how do we know when this is something we should be medicated for or not?
Right.
And we should be able to conquer it.
Yeah.
If I'm
And
sad
especially if you're a physician who's young and think this is just something, this is a roadblock, this is another hurdle,
right.
this is
right.
the MCAT,
Well,
I got
gets
this.
that gets to the burnout thing, which is another thing.
Yes,
But
well, let's
anyway.
get into the burnout
Okay,
thing.
we'll
Yes.
get into the burnout
so
thing.
we've set ourselves up, and we had a nice little side conversation there. But with regard to physician burnout, my previous job was dealing with teaching physicians, nurses, techs, etc., how to use Epic and EHRs. And
Can I have a lesson when we're done? No, I'm
yes,
kidding.
absolutely. So
I hate
just
it. I hate it.
Yes. Well, I told people when
I'm
I worked
sorry.
there, it is simultaneously the best invention and the worst
The worst,
invention.
right,
It's dynamite. It really is. Like, you can change your life.
Someday it will be dynamite.
Mm-hmm.
But let's take Epic and burnout, because certainly there's a lot of talk about. It's not just Epic. though.
Sure.
I mean,
Well, yes.
it's not just the EHR. The problem with the EHR is that the doctors now are very focused on entering data into the EHR. So they're not focused on the patient. I mean, all of us, even me, I go to see my internist. You can see in my office, we can tell this to our listeners, my computer is over there, and I'm usually sitting like we are.
Sure.
But there are times when I have to turn around and do this. And if I'm sitting in my doctor's office, he's like you there. He's looking down, he's looking up, he's looking down, he's looking up. So he's talking to me, but he's typing at the same time. So that really removes a lot of the human connection. Plus, Epic, as you know, was designed for scheduling and billing. It was not designed for clinical care. Yes, the money, I know.
Yeah.
But it was designed that way. And the people who designed it, I mean, I cannot. There are so many things on the screen that I can't figure out. I have to go sign off on being an overnight attending for one of my residents. I know there's something I'm supposed to do. I can't for the life of me remember because I don't do it enough because I'm not on enough. But the screen is just covered. So there's no way for me to isolate what's really important. And I think we've talked about this a lot, that at some point Alexa will sit there, listen to us, and extract everything. People are so carried away with what they can document that it's lost its meaning, and no one wants to say this is what's really important and this isn't. And clearly, doctor's handwriting was always a joke.
Right.
You could never read anything, but you can't find anything. And the kids who are learning now, they're cutting and pasting, so they're not learning how to think. So there's a lot that's problematic that I know someday will be better, I hope. But my fantasy and my fear is, the virtual doctor on Star Trek.
Yeah.
That we're all going to turn into virtual people.
It's really, it could be so good and so bad, because I remember when I first started in medical media, listening to a talk at ASCO about how sending pictures of your skin lesion to your oncologist, and they can say, don't worry about it, or you need to come in.
That's great.
But that's one aspect of it, right? But the other aspect is, here, just log onto your computer and here's your script.
Exactly.
And that's, it is a fine line where they're going. For
so
sure.
The problem, the burnout piece. So burnout technically refers to things like depersonalization, emotional exhaustion, loss of connection, loss of meaning. And what's happening with the computer, which has done some good things without question, is that doctors are going home and they're spending 2 and 3 hours at home doing their notes on the computer. And the pace of the need to turn over patients, the primary care visit reduced to 8 minutes.
Yeah.
It's over and over. So there's no time to develop a relationship. And if we look at how hard medicine is, you're dealing with people who have illnesses, who can die, that you're trying to help. In the most important area of anyone's life is your health, right?
Sure.
If you're not healthy, you're not here. Okay.
Right.
So, and you sacrifice a lot to do it. And if you remove those very things that give us meaning in the work we do, it's like, why do it?
Yes.
And you get demoralized, depressed, angry, exhausted. You want to go home. You just can't wait to get out of here. Patients really become objects. We get short with each other, and there's all the other thing that happens is that there's a lot of focus on being civil. We just got a thing. I shouldn't say this on the air, but something that about how discipline's important and we should be kind to each other. But people, they talk the talk, but they don't walk the walk.
Sure. Thank you all for listening to the MD Edge Post-Call podcast. Dr. Bernstein was featured on a previous episode of the MD Edge Psychcast. A link to that show is available in the podcast notes. Part 2 of my conversation with Dr. Bernstein will air as the 11th episode and will be available on Friday, December 14th, wherever podcasts are found. For Dr. Bernstein and all of us here at MD Edge, I'm Nick Andrews, and this is the Post-Call podcast.